these were really very, very fascinating discussions because they're talking about anatomy and physiology together. I'd like to first just make the case of these objectives. First, to discuss the ontogeny of sleep and sleep state development in infancy and why it's so important for early diagnosis. Describe the physiology of obstructive sleep disordered breathing in children, infants and children. Explain the importance of the early diagnosis and what the effect may have long term. And there's a fourth one there, is to try to keep everybody awake because it's been a long afternoon. So I hope I can fulfill one or two of these objectives, and hopefully the last one that's not here. It's fascinating how infants develop and how the infant brain develops, because the infant, before they're born, they're spending almost all their time sleeping. About 80% of the 24-hour day is spent sleeping, and about 90% of that sleep prior to term is dream sleep. And I think that's important to remember, because neurons and synapses develop by neurons being stimulated, and the only way that they can be really stimulated prior to birth is by dreaming, because the brain is very active during dreaming. By term, about 50% of the total sleep time is dreaming, and 50% is non-dreaming. And when we are in non-dream sleep, and the way the brain develops is by stimulating it, and stimulating it either by dreaming or by interacting with the environment. I'm going to try, and the fourth objective was really important because I'm going to talk about some really boring things. One is the EEG. Boring. Really boring. Second, I'm going to talk about physics, and that is really boring. And third, I'm going to talk about some mathematics, which I think is very soporific, so if you have insomnia, play the lecture over and over and over again. At about 28 weeks gestation, we can first start seeing electrical activity in the brain. There are a paucity of neurons in the cortex, so that we don't see very much activity, and the activity that we do see is called a discontinuous pattern, where and the top line is the EEG that we see. It's a schematic of the EEG that we see in a very premature baby, 28 to 30 weeks. And it's called a pattern of trace discontinu, a discontinuous trace, where there's a period of relative electrical quiescence that's interrupted by periods of high voltage activity. And this is pure cortical activity from a very, very small number of neurons. And that's what that looks like. As the baby develops, and as 36 weeks to 38 weeks gestation arrives, we get a pattern of trace discontinu. We see the non-REM or non-dream sleep pattern like this, where that period of relative electrical quiescence is smaller. The period where there are high voltage slow waves becomes longer, and that's because the cortex is becoming more populated. There are more neurons that are gravitating to the cortex. There are more synapses that are being connected. I'm going to get really confused with all these both in both hands. And that's what that looks like. Now, at term, by 38 weeks to 42 weeks post-conception, this is the kind of pattern that we see, because now the cortex is somewhat populated, and you have cortical activity. You have good population of midbrain and lower brain stem centers, and you have little or few connections, though. There are fewer synapses that have developed in order to drive the cortex in certain ways. And that's what that looks like. So you can see a pattern here of development of the EEG from a very discontinuous pattern to one that's becoming more adult-like, where there are more neurons in the cortex and more activity. As cortical connections are developed with lower brain stem, midbrain, and cortical structures, it all fuses together into high voltage slow waves, so that we have a continuous synchronous slow wave pattern, and then it starts becoming faster. You have high voltage, faster activity, and this is the progression to what we have at around term, or around 1 month of age. Once the connections are really established at about 3 months post-term, you have nice driving of the cortex, and you have certain waves that are seen only during sleep, and those are K-complexes here, which are high voltage slow waves with an initial negative deflection followed by a positive deflection. You see sleep spindles, which are really fast activity that are spindle-shaped on the EEG, and it's separated by relatively low voltage mixed frequency activity. And it looks like that. And as we get older, it becomes more consolidated, it becomes clearer, it becomes faster activity, and it separates. Then non-dream sleep separates into distinct states. Not just non-REM and REM, but non-REM transitional sleep, non-REM stage 2, non-REM stage 3, where there is high voltage slow waves throughout, which is indeed pure cortical activity. It's not being driven by lower centers. And so you get separation of non-dream sleep into two clear states, one where there are K-complexes and sleep spindles and high voltage slow waves. In 2013, Maiden Nadergaard, a brilliant researcher, identified the difference between identified the clearance patterns of beta amyloid from the brain. And what she found was that beta amyloid is only cleared from the brain during sleep. They're not lymphatics, they are glymphatics because they're created by glial cells in the brain that surround arterioles and venules within the brain. And the pulsations move the intracerebral fluid into the cerebrospinal fluid to be excreted from the body. Fascinating. Maybe that's why we sleep. Because we need to sleep to open these channels in order to clear the brain. What's it doing in children? Children sleep a lot longer. Peter Huttenlocher from the University of Chicago spent a career counting synapses of babies, infants, preemies, newborns, young children, and he even looked into adulthood. And this is a spectacular chart because it shows that the newborn has about 10 to the 8th synapses per cubic millimeter of the brain. And you can see that as time goes on, by 5 years, Kevin's 72 weeks, the brain reaches the total number of synapses that it will ever have. It will not have any more after it decreases. Now, it doesn't mean they can't be reconfigured. It doesn't mean they can't be reshaped. But the total number of neurons, the total number of synapses that we have within the central nervous system stops at 5 years of age. So the first 1,000 days, the first 5 years of life, are probably the most important part of brain development, the most important part of our lives, where we develop our brain to a point where we are not going to really develop it anymore anatomically. We are going to develop it more physiologically, and we're going to develop it more functionally, but we have to have the tools in order to develop it, right? If you build a car, and that car doesn't have a carburetor, well, they don't have carburetors anymore, fuel injectors. If they don't have fuel injectors, that is going to look like a car, it's going to sound like a car, it's going to smell like a car, but it's not going to work. It's not going to work the way we want it to work. And therefore, the brain is the same as the car. We're building the car over the first 5 years of life, and then we're making it run. We're filling it with gas during that period of time in order for it to function appropriately. So, what we do to our brain between 28 weeks gestation, when we can first start seeing electrical activity, through the first 5 years, is going to affect the rest of our lives. Now, this has been ignored very significantly. And it's been ignored significantly because the pathology that occurs is not major pathology. When you say that a child has been oxygen deprived during this period of time by obstructive sleep disordered breathing, periodically, these children don't develop severe, obvious neurologic deficits. It is very unusual. But what we don't know what it does long term. Is this infant apnea or infant hypoxemia or intermittent hypoxemia that these children have with obstructive sleep disordered breathing? Does it affect them long term because when they get to be 6, 7, 8, 9 years old, they can't read? They have difficulty paying attention. And maybe, Kevin, there is an attention deficit disorder, attention deficit hyperactivity disorder, that may be a result of this, but we don't know. And when Kevin and I talk a lot, I always tell him, Kevin has to pass the so what test. I don't know. These are questions that we have to answer, but we do know from animal studies, which we'll see in a little bit, how important it is to have good oxygenation during this first 1,000 days of life. And by the way, Peter Huttenlocher, he did all of his stuff by looking at these brains under microscopes, and he counted them by hand. And at this point, oops, what am I pressing? At this point here, there are about 16 times 10 to the 8th synapses per cubic millimeter. That's 1,600,000,000 synapses per cubic millimeter of cortex. That's a lot. So if we lose some, there's probably duplication and backups, but we don't want to lose too many. His data are just spectacular. Now I'm going to talk a little bit about why we have obstructive sleep disordered breathing in children and how it differs from adults. This is the adult airway, which you've been seeing very frequently. This is Dr. Netter's beautiful drawing of the infant airway, and it's different. Children are different than adults. They're different anatomically and physiologically. This pediatric airway functions very much like a Starling resistor. Here comes the physics, so I'll point out anybody with the laser that snores. It functions like a Starling resistor. And how many know what a Starling resistor is? Okay, most. Half. A Starling resistor, it basically says that you can pinch and narrow the airway or narrow a tube at a particular point, and it transmits negative intraluminal pressure downstream so that anywhere along that passageway, you get negative intraluminal pressure. What we have been looking at so far, for the most part, has been bony landmarks. And the airway is an interesting thing. It's like a straw. If you look at laminar flow in a tube, it's like a straw that's wet in the middle, because this is bony and cartilaginous. The nasopharynx is bony and cartilaginous. The trachea is cartilaginous, so it's hard, it's firm. It does not tend to collapse. So the upper airway, the bony nasal airway, doesn't tend to collapse. This area right here between the tongue and the posterior nasopharynx and the hypopharynx is muscle. And there is nothing else that is supporting that other than tissue that's connected to bony landmarks. But it's muscle, so it's that wet part in the straw. So if you narrow this upper airway here, you're going to create, according to the Starling resistor law, greater negative intraluminal pressure throughout this entire passageway. And where is it going to collapse? Where is it going to become narrowest? When the critical closing pressure of the airway is exceeded, it's going to collapse right in here. So what do? You try to make this bigger. You try to make this bigger by taking tonsils and adenoids out. You try to make the nasopharynx bigger. You can decrease the size of the turbinates. You can increase the rigidity of the epiglottis and the tracheal rings by doing supraglottoplasties or epiglottopexy. But any way to open up that airway and make it bigger is important, because we'll move on to the next bit of physics, and this is the math that I was talking about. This is Poiseuille's law solved for resistance, of laminar flow in a tube solved for resistance. And Poiseuille's law, when solved for laminar flow, when solved for resistance here, is 8 times nu, which is a viscosity factor. And the viscosity factor is important because you can drink through a straw and get water up fairly easily through a straw when you're drinking it from a cup. You can't get maple syrup up as easily. And you can't get honey up as easily because of this issue. It's the viscosity of the fluid that you're trying to move. And we're moving air, which is a viscous gas. Oxygen and helium, 50% helium, 50% oxygen. You're treating the airway by treating this viscosity factor times the length of the tube. Adults have long tubes. Babies have very short tubes and very small tubes. And it's divided by the radius of the tube raised to the 4th power times pi. So what that means, for those of us who are not mathematicians, is that for the smaller the airway, a minuscule change in the radius of that airway, or anywhere along that airway, will result in a huge change in the resistance. So just narrow the airway a little bit, and the resistance goes up dramatically, almost 8-fold to 16-fold, r to the 4th. Okay? On the other hand, if you open that airway, that little airway, you only need to open it a little bit in order to change that resistance a lot. So a very, very small change in the radius of the airway will result in a significant change in the resistance and either resolve or exceed the critical closing pressure of the airway. And the critical closing pressure of the airway is the amount of negative pressure, intraluminal pressure, at which the airway will totally collapse. Now, why is that important? These are two obstructive apneas. This is a 60-second epic. And the top is EEG, and this is electrooculogram, but this is a bipolar transcoronal array with a posterior channel. And you can't see it very well because it's 60 seconds, and you need to look at it at 10 seconds to see all those other waves. EKG, this is the heart rate, this is a finger, the pulse volume, chin muscle EMG, left leg, right leg. This is the nasal pressure. This is the end-tidal CO2 and the end-tidal CO2 waveform. So we measure in the laboratory carbon dioxide being exhaled from the nose and mouth. We measure the pressure of air being exhaled from the nose and mouth. And this is the chest effort. This is an intercostal EMG, basically diaphragmatic activity, and the bottom is abdominal activity and oxygen saturation. If you look here, things stop. If you look here, it continues. These are actually three obstructive apneas, one here, and one here. And it results in a little bit of oxygen desaturation. What happens, though, if you have these apneas? And this is an example that was done by Dr. Ferre and Ghazal and published just last year on mechanisms of causing obstructive apnea in rats. And they had air pumps here, and there was a balloon on the end and occluded the airway in the rat here, and the balloon went down. And they periodically caused airway obstruction in these experimental animals. And this is the esophageal pressure, so that you can see the esophageal pressure during inspiration and exhalation in these animals here, which is pretty normal. And then the negative intraluminal esophageal pressure becomes greater and greater and greater until the resolution of the apnea. So these are mimicking that previous slide that we saw. This is what would be happening in that child. Now, if we look at what happens to the oxygen saturation in these mice, it falls during periods of apnea. And then it goes back up, and it falls again, and then it goes back up, and it falls again and goes back up. So periodically, throughout the night, a child who has obstructive sleep disordered breathing will have hypoxemia and then normoxemia. Hypoxemia, normoxemia. So there'll be intermittent, periodic desaturations. For how long those desaturations occur, when does that become clinically significant is unclear. We don't know. The metric is the obstructive apnea-hypopnea index, which everyone has been using since the 70s in order to describe obstructive sleep disordered breathing in adults and children. Is that the right metric? I don't know. I don't know whether an obstructive apnea plus hypopnea index, an AHI, we don't know if that's the right metric to look at, or whether it's an oxygen debt issue that is causing the problem or causing the sequelae of obstructive sleep disordered breathing. We do know that in the laboratory animals with sleep fragmentation, that they will end up having similar kinds of physiologic changes as those that occur with intermittent hypoxemia. This is what a sleep study looks like in a child with obstructive sleep apnea. Looks very much like the other, like the experimental animals, where this is the sleep architecture, where this is non-REM N3 sleep, the blue is REM sleep, and this is pretty normal sleep architecture. But look at what happens during REM episodes. There's periodic desaturations, hundreds of them. And these are for seconds, where the oxygen saturation will fall and then go right back up. We see this all the time in the hospital, when the children are being monitored in the neonatal intensive care unit or in the pediatric intensive care unit or on the floor, the nursing staff say there were no desaturations at all at night. None. Because why? They came into the room here and looked at the pulse oximeter, and it was 98%. And they came into the room here because they do vital signs 3 times during the shift or 4 times during the shift. And they came in here, and the oxygen saturation's 98%. And they came in the room here, and it's 98%. What was missed were these periods of REM sleep where there were clear desaturations and sleep fragmentation with snoring, some limb movements, respiratory events that are identified by these little tick marks here, and arousals. So you can see them concentrated here during REM sleep and concentrated here during REM sleep and concentrated here. And also, we don't have a transcutaneous carbon dioxide level, but you can see that during the REM sleep episodes, it tends to be a little bit greater. The carbon dioxide tends to be a little bit greater. The effect of the carbon dioxide has been studied in laboratory animals, but is not as clear as the intermittent hypoxemia. We do know that when someone becomes hypercarbic, there's intracranial shunting of blood to other areas. So it's important. The carbon dioxide is likely as important as the intermittent hypoxemia. So let's put it all together. We looked at the first 1,000 days, the development of the nervous system in infants during sleep. We looked at the physiologic underpinnings of obstructive sleep disordered breathing in children, and the possible and potential consequences. If you take, and it has, the experiments have been done at the University of Wisconsin, where kittens were enucleated at birth, and their lateral geniculate bodies were looked at. If they were enucleated at birth, they had no neural migration to the LGN, the lateral geniculate body. Sighted cats had normal population. If they when the researchers took an electrical stimulus and stimulated the third nerve in these kittens, the lateral geniculate body looked normal. So stimulating nerves and stimulating the development of synapses and neural networks is exquisitely important, and we saw from Dr. Huttenlocher's exquisite studies that we go till 5. We build till 5, and then we start losing it after we're 5. So the book that we all probably have read before, Everything I Needed to Know I Learned in Kindergarten, is probably true. After that, it's just fixing things in the right order rather than creating new things that we can build. And the creation would be of new neural networks, but not greater number of neurons or synapses. Thank you.
Question? Yes.
So you build until 5 with number of synapses. So is there, whether it's intermittent hypoxia, less REM sleep? There's studies that show, Anna Alvar, Johns Hopkins, showing that with reduced REM sleep, certainly, or fragmentation of REM, you get possibly even destruction of neural pathways, stuff like that. So is there anything that shows that if you are having those kind of sleep issues, whether it's hypoxia or fragmentation, you actually form fewer synapses, or?
That I don't know, because I don't think that study could be done. because it would Peter Hutenlacher counted them, and so he needed a brain. And you can't do that study and then have a control group. But what Robert Stickgold has done from Harvard has REM-deprived college students and found that, and also sleep-deprived them, and found that they perform poorer, they learn less, they retain less, and memory consolidation is extremely poor following REM deprivation as well as total sleep deprivation and non-REM sleep deprivation. So if learning is developing neural networks and creating new neural networks from established ones, then we can hypothesize that by depriving one of REM sleep after a learning task, we are not creating those neural networks and perhaps destroying networks that could have been made or that had been made before. So indirectly, I would say, yeah, if you don't sleep and you don't dream, you're not going to learn and you're not going to remember. The other correlate to that, which I think is really interesting, and I still believe that ADHD doesn't exist. And I didn't whisper to Kevin, I shouted it from the rooftops, and the head of the psychiatry in my hospital didn't talk to me for almost 5 years because she is a researcher in ADHD. But this is the premise. The premise is that it's a name that we're talking about, and by making it a disorder, is it really a disorder or is it not? It's really not a disorder if you use the classical definitions from Stedman and Dorland, that it's a syndrome. When I first started in medicine a long time ago, and when I started in medicine, it was called MBD, minimal brain damage, and I actually have a book in my office that's titled Minimal Brain Damage, MBD. Well, it was found that there wasn't much damage in these children, and so they liked the acronym MBD, and everybody knew what MBD was, and so they changed it. Well, maybe it's minimal brain dysfunction. They looked for dysfunction, and the brain really wasn't dysfunctional. But they needed an acronym, so they changed it to attention deficit disorder with hyperactivity and without hyperactivity. Then they didn't like that, so they changed it to attention deficit hyperactivity disorder, so ADHD. Well, I would recommend that it be changed again, and maybe stop changing it, because it's a syndrome. Dorland's Medical Dictionary and Stedman's Medical Dictionary define a syndrome as a complex of symptoms, and that's how you make the diagnosis of attention deficit hyperactivity, whatever it is. Whether it's a disorder or whether it's a disease, I don't know. You can cause the same symptoms with lead poisoning. So is that ADHD? I don't know. And it doesn't take a blinding leap of faith to understand that a sleepy child, if you give them a stimulant medication, they will wake up. Right? So, this attentional dyslexia that children develop, which may be related to this intermittent hypoxemia, which may be the disorder of attention, a disorder of attention later on in life. But we created it in a laboratory. Not a laboratory, it was a sleepover. We were studying pupillary reflex and pupillary noise in children that we sleep deprived, 7, 8, and 9-year-olds. And took normal 7, 8, and 9-year-olds, and we studied them for 2 weeks with an active watch to make sure that they were sleeping. They slept 10 hours. And the variance between the number of children that we studied was about 1.2 hours per night. Their average was 10 hours of sleep per night, which is pretty normal, 10 to 11 hours. That's pretty normal. Our research protocol said that they would come into one of the parents' homes, and we'd have a slumber party. We had we studied them the first day that they came on Saturday, and all they were required to do was go into a dimly lit room for 5 minutes, so that there was dark adaptation for 5 minutes, and then stare into the pupillometer tube for 18 seconds. That was all, and then they were done. So we're talking about 5 minutes and 18 seconds worth of attention that we needed from them. The data were, and by the way, the data were collected in 9 seconds. 18 seconds was just so that if they happened to look away from the tube. The first day, no problem. We got great data. Then we had child life therapists, and we had activity therapists, and we had movies, and we had clowns, and we had magicians to try to keep them up. We couldn't keep them awake. Our protocol said that they were going to sleep only 5 hours, but we couldn't keep them awake so that they would only sleep 5 hours. They started falling asleep in the kitchen. They were falling asleep on the floor. One fell asleep on the toilet. They were falling asleep everywhere. And we had an Acti-Watch on them, so they slept during the study night, the deprivation night, 6 hours with a variance between subjects of 0.6 hours. So it was they were all sleepy, and we could not keep them awake. We woke them up the next day, and we did 2 measurements at 10 o'clock and at 2 o'clock during the day. The next day, I was blinded to even when the study was being done. Monday morning comes, and our postdoc, his name was Tom Katzos, who was the most jovial person in the world. Every time you talked to him on the phone, "Hi, how are you? We're so excited about doing this. We're going to do this all the time." He called Monday morning, said, "Stephen." "Hi, Tom." "Hi." "What's going on?" "We did the study." "What happened? Tell me about it." "Don't you ever make me do that again." He said that on the second day, the children were wild. They're bouncing all over the place. They turned off his computer. They turned off the pupillometer. He had to catch one running down the street in order to get them to stay in the room for 5 minutes. They were impulsive. They were overactive. They couldn't pay attention to anything. They were fidgety. They were moody. They were distracted. They couldn't pay attention to reading a book. So what did we create? We created children that had attention deficit something by just sleep depriving them 4 hours from their normal total sleep time. Now, imagine this in a classroom where a child is sleepy and has these micro sleeps, because you can't sleep deprive a human until they die. In fact, one of my other favorite sayings is that sleep is more important than food. You aren't what you eat, it's how you sleep. That's the important thing, not food, because you can nutritionally deprive a human until they die. You can nutritionally deprive a lower animal till they die. You can sleep deprive a lower animal till they die, but you can't sleep deprive a human until they die. So teleologically, it's more important than food, because what happens is that we start sleeping when we're awake, or we fall asleep uncontrollably for a certain amount of time until whatever it is that we're ridding our body of or we're recovering from is recovered, returns. Therefore, can you imagine a child who is sleep deprived sitting in class and listening to the teacher describing Poiseuille's equation and miss the second half because they were falling asleep. It's like when you're reading a book late at night. How many read at night? Most. Okay, good, 90%. The rest of you are probably sleeping now. But if you read at night, when you get to a point where you're reading the book and you read from the top to the bottom, you have no idea what you read after you turn the page. And so you turn it back and you read it again from top left to bottom right, and you have no idea what you read. And so you read it again. That's the time that you were falling asleep. Because from the time you started at the top of the page till the time you got to the bottom, you were in transitional sleep. And during transitional sleep, we perform automatic behaviors. So we do essentially whatever we were doing until we consolidate sleep, and then we stop. But things don't get in. You just don't consolidate what you were reading, and you can't incorporate that into what you were thinking. So take the child that's doing that during the day. They don't have a chance. They really don't have a chance to learn. Because even if they can learn, if they take a test and they're asked to read a stem on a standardized test and then look at 4 distractors, they're asleep at the end of the stem. They read only the first 3 distractors and then fall asleep and don't remember seeing the other ones because they were reading that book late at night. That's why if you're there with chronic sleep deprivation, if someone is given a stimulant, they will perform better because they are being forced to be awake. We all use it. We do. All of us use it because when we wake up in the morning, we have our coffee. And at lunch, we may have some more coffee. And some people even have coffee at dinner or after dinner. And that is treatment. Some people have 16 to 20 cups of coffee a day because if they don't have it, they can't perform. They're sleepy. They're sleepy people. We are a sleepy society. We have sleepy children. We have sleepy adults. What we want to prevent, though, and what this whole symposium is about is the bones that we looked at, optimizing bony structure so that the nasal airway can be as big as it possibly can be, optimizing the muscular structure that is the floppy part of the airway so that it can be as strong as it can be, and what you're doing is you're changing the critical closing pressure of the airway. So that rather than having a negative 10 centimeters of water pressure intraluminal as a critical closing pressure, you need 20 intraluminally in order to collapse that airway. So you're looking at muscle, you're looking at bone, and you're trying to optimize that so that we don't have periodic, intermittent hypoxemia that will affect brain growth, affect neural migration, and neural network development with synaptic growth and development. That was a long-winded answer for a very simple question. And I could talk about that all day. Are there other questions? Yes.
I'm especially referring to ENT for that early child, 7, 8, 9. I would even say for 4 through 9, they'll say, well, developmentally, my tonsils and adenoids can be enlarged, and they're all waiting for that birthday to come and go.
I apologize. Can you?
Sure. So what we find is when we're making recommendations for tonsil and adenoids, and especially with if we're concerned about sleep disordered breathing, a lot of times the ENTs are telling the families that there is a developmental period where those enlarged tonsils and those enlarged adenoids can reabsorb. Therefore, I wouldn't do anything until that point. But then going back to Joy's point is we want to intervene before 7, but at the same time, we're not able to address it because maybe the airway is affected, but nobody will address the airway being affected because developmentally that could be the reason.
You're exactly right. That issue can be profound with people who don't know anything about sleep disordered breathing or the effects of intermittent hypoxemia during the first 1,000 days of life. Yes, it is true that that developmentally tonsils and adenoids grow as the youngster grows, and then after a certain age they begin to regress. 7, 8, 9, they begin to shrink. And not only do they begin to regress, but the airway is getting bigger. And based on Poiseuille's law, the larger the airway, if you have the same change, is going to cause less change in the resistance. So the larger the airway, the less resistance there will be, and the less chance that critical closing pressure won't be exceeded. The problem is earlier. I mean, when are you going to pull the ripcord on the parachute? You can do a high altitude, low opening. That's fine, right? But if there's no issues with your finding the ripcord, then that's fine. I mean, but if you miss it, you're in less trouble if you start looking for the ripcord higher before you get to that critical point where you need to pull it. And so the critical time with what we've shown here is really the first 1,000 days, the first 5 years. If you don't get it by the first 5 years and stop this intermittent hypoxemia, who knows what you're doing to the youngster long term? And this is the biggest issue that this group has, and Kevin and I discuss this all the time. The studies that would be required to prove what we are talking about would take 20 or 30 years to do. Plus, they are inordinately expensive because you have to prove that what you're doing by expanding the nasal airway makes a difference. So what? That you expanded the airway? Is it making a difference in oxygen saturation? Is it making a difference it may make a difference in the obstructive apnea plus hypopnea index, the AHI. It may do that, but so what? If that's the wrong metric, then we're looking in the wrong place. So I think that you got to get it before 5. Thank heavens, this is not wood. It's somebody knock on wood for me. This is metal. At Lurie, our ENT department is spectacular. I think almost all of them are very well trained in sleep. And they do outstanding sleep histories. We do sleep endoscopies, which are extremely helpful. We have the speech and language department that does myofunctional therapy. Fabulous. So we're lucky because they'll take a 2-year-old in and take their tonsils and adenoids out to give them more room. Or they'll do an adenoidectomy on a 2-year-old. They'll leave the tonsils because the adenoidectomy is pretty simple. They'll do that. We have shown in one study with Mark Gerber in our laboratory that the partial debridement, partial tonsillectomy, is effective in decreasing the AHI. I don't know whether or not that is solving a long-term problem, but it certainly changes the recovery and is less painful.
What you just said about we have to wait 20 or 30 years before we get the right type of research. The problem I see is, and I've been doing it 43 years, a long time, I've seen the deterioration of people over that time so much worse than it was 40 years ago. People have changed. And 30 to 40 years from now, that's what's scary. If we have to wait for that conclusive research.
Yeah, I totally agree with that because it's interesting because Sir Isaac Newton discovered gravity, right? When the apple fell on his head, at least that's the way the story goes, right? What proof did he have? Not much, other than it fell on his head. And we are at a point now where the apples are falling on all our heads. We don't have proof. We have anecdotes. And anecdotes, that's not proof. You need evidence-based scientific data in order to prove what we think is happening. And until then, we need to treat based on our judgment. And judgment and experience, yes, but based on the judgment that first we do no harm, and second we do what we think is empirically right for the patient, because the patient's always right. The other, just to add to the confounding difficulties, is that if there are 300 billion people in the world, there are 300 billion different variables that we have to control for. And you can't control for all those variables. So having really clear evidence-based approach to diagnosis and management is exquisitely difficult right now. Another, just to add to that also, we did, in the American Academy of Pediatrics, did every 10 years reviews literature on OSA in children. And in 2012, we did a comprehensive review of the last 10, it actually was 12 years. There were only 350 studies in 11 years that had adequate basis for evidence of either level 1 or level 2 evidence. 350 studies. That's nothing. And we were using the AHI as the metric. And the metric may be wrong. We may be looking at the wrong thing. So now we have I've been doing this for 45 years, and I have interpreted about 47,000 pediatric polysomnograms. I don't know what I'm looking at, and I've looked at that many. And I still don't know if I'm looking at the right thing. So what we need is to approach it in a technological way, so that with technology and AI really is going to solve a lot of these problems by being able to do these studies less expensively and on large numbers of people, because we can't do that now. You know, an N of 10 is great, but what does that prove? Not much.
It's a great time now to give Dr. Sheldon a round of applause.